Hi everyone, my name is Zahaya Zamanfas, and today I would like to present on the 2006 cholera outbreak in Ethiopia's Oromia region. Cholera is an acute infection of the small bowel. It is a Greek word which means the gutter of the roof. It is caused by the bacteria Vibrio cholera, which was discovered in 1883 by Robert Koch during a diarrheal outbreak in Egypt. Vibrio cholerae, the organism that causes cholera, is a comma-shaped, gram-negative aerobic bacillus whose size varies from 1 to 3 mm in length by 0.5 to 0.8 mm in diameter. Its antigenic structure consists of a flagellar H antigen and a somatic O antigen. It is the differentiation of the latter that allows for separation into pathogenic and non-pathogenic strains. Since 1817, there have been 7 cholera pandemics. The first 6 occurred from 1817 through 1923 and were caused by Vibrio cholerae, the classical biotype. The pandemics originated in Asia with subsequent spread to other continents. The 7th pandemic began in Indonesia in 1961 and affected more countries and continents than the previous 6 pandemics. It was caused by Vibrio cholerae altor. In October 1992, an epidemic of cholera emerged from Madras, India, as a result of a new serogroup, 0139. Some experts regard this as an 8th pandemic. This Bengal strain has now spread throughout Bangladesh, India, and neighboring countries in Asia. When it comes to cholera, crowding and gathering of people during religious rituals, for example, Muslims pilgrimage to Mecca or Hindu swimming festivals in holy rivers, enhance the spread of infection. Index cases when travel back to their homes may pass the organism to at-risk individuals, leading to secondary epidemic or small-scale infection. The number of cholera patients worldwide is uncertain because many cases are unreported. The number of cases is increased during epidemics and is affected by environmental factors. In 1994, 94 countries reported 385,000 cases of cholera to the World Health Organization, but the number reported in 1998 was 121,000. 89% of these cases were reported from Africa. Vibrio cholerae cause clinical disease by producing an enterotoxin that promotes the secretion of fluid and electrolytes into the lumen of the gut. The result is watery diarrhea with electrolyte concentrations isotonic to those of plasma. The enterotoxin acts locally and does not invade the intestinal wall. As a result, few white blood cells and no red blood cells are found in the stool. Fluid loss originates in the duodenum and upper jejunum. The ileum is less affected. The colon is usually in a state of absorption because it is relatively insensitive to the toxin. The large volume of fluid produced in the upper intestine, however, overwhelms the absorptive capacity of the lower bowel, which results in severe diarrhea. Cholera is transmitted by the fecal-oral route through contaminated water and food. Person-to-person infection is rare. The infectious dose of bacteria required to cause clinical disease varies with the source. If ingested with water, the dose is in the order of 1,000 to million organisms. However, when ingested with food, fewer organisms are required to produce disease, namely 100 to 10,000 organisms. Vibrio cholerae is a saltwater organism, and its primary habitat is the marine ecosystem. Cholera has 2 main reservoirs, man and water. Animals do not play a role in the transmission of disease. Vibrio cholerae is unable to survive in an acid medium. Therefore, any condition that reduces gastric acid production increases the risk of acquisition. The incubation period for cholera is 1 to 3 days. Symptoms begin with sudden onset of watery diarrhea, which may be followed by vomiting. Fever is typically absent. The diarrhea has fishy odor in the beginning, but becomes less smelly and more watery over time. The classical textbook rice water diarrhea, which describes fluid stool with very little fecal matter, appears within 24 hours from the start of the illness. In severe cases, stool volume exceeds 250 ml per kilogram, leading to severe dehydration, shock, and death if untreated. The Vibrio cholerae organism can be seen in stool by direct microscopy after gram stain in dark field illumination is used to demonstrate motility. Cholera can be cultured on a special alkaline media like triple sugar, agar, or TCBS agar. Serologic tests are available to define strains, but this is needed only during epidemics to trace the source of infection. The primary goal of therapy in cholera is to replenish fluid losses caused by diarrhea and vomiting. Fluid therapy is accomplished in two phases: rehydration and maintenance. Rehydration should be completed in 4 hours, and maintenance fluid should replace ongoing losses and provide daily requirement. In fluid therapy, ringer lactate solution is preferred over normal saline because it corrects the associated metabolic acidosis. IV fluids should be restricted to patients who purge greater than 10 ml per kilo per hour, and for those with severe dehydration. The oral route is preferred for maintenance, and the use of ORS at a rate of 500 to 1000 ml per hour is recommended. The goals of drug therapy are to eradicate infection, reduce morbidity, and prevent complication. The drugs used for adults include tetracycline, doxycycline, cartrimoxazole, and ciprofloxacin. For children, erythromycin, cartrimoxazole, and forzolidone are the drugs of choice. Drug therapy reduces volume of stool and shortens period of hospitalization. It is only needed for a few days, 3 to 5 days. Drug resistance has been described in some areas, and the choice of antibiotics should be guided by the local resistance patterns. Antibiotics should be started when cholera is suspected without waiting for lab confirmation. In late June 2006, there were reports of cases of acute watery diarrhea in Ethiopia's Oromia region. Cases were first noted in the town of Shashamene, the western part of the RC zone. Ethiopia is divided into 9 regions, and each region is further subdivided into zones. Shashamene is located along a major river system, allowing for quick spread of the disease. Stool specimen collected from patients from the western part of the RC zone confirmed Vibrio cholerae 01 serotype to be the causative agent, a significant finding given that cholera is not known to be endemic to Ethiopia. Despite the efforts of the regional government and the district health bureaus, the disease quickly spread from the original 3 districts to 10 districts within the western part of the RC zone, and from there to the neighboring zones of Guji, Bale, and East Shawa. The outbreak swiftly crossed regional boundaries and spread into southern nations, nationalities, and people region, and into the northern region of Tigray and Amhara. The situation in Oromia was particularly concerning. By mid-September, there had been more than 19,000 reported acute watery diarrhea cases. The Oromia Health Bureau, although working to contain the cholera epidemic, did not have the public health capacity to properly investigate the extent of the outbreak. The number of cholera cases and deaths in the community remain largely unknown. Essential supplies such as oral rehydration salts, intravenous ringer lactate, chlorine, and antibiotics were lacking at some health posts. Although multiple non-government organizations were responding to the outbreak, leadership, coordination, and communication were lacking. During the early phase of the outbreak, stool specimens were collected from patients from the western part of RC zone, which was used to confirm Vibrio cholerae 01 serotype to be the causative agent of the outbreak. During the outbreak, cholera case definition was utilized in the following manner. A case of cholera should be suspected when in an area where the disease is not known to be present. A patient aged 5 years or more develops severe dehydration or dies from acute watery diarrhea. In an area where there is a cholera epidemic, a patient aged 5 years or more develops acute watery diarrhea with or without vomiting. At the health post and at community levels, a suspected cholera case can be defined as follows. Any person 5 years of age or more with profuse acute watery diarrhea and vomiting. A confirmed case is when a suspected case in which Vibrio cholerae 01 or 0139 has been isolated from their stool. To investigate the cholera outbreak in Ethiopia's Oromia region, a retrospective case study was conducted using a purpose sampling method to survey Health Bureau staff and cholera treatment center staff and community members. The study population were residents of the three districts, Guji Zone, East Shoa Zone, and Bali Zone, which were affected by the cholera outbreak in 2006. The total population for the study was 861,670 people. The cholera cases were mapped along the Gnali River, which runs between the zones of Guji and Bali to the lakes at the southern tip of East Shoa. East Shoa and Bali had similar numbers of cases, 233 and 223 respectively, whereas Guji had a significantly higher number of reported cases, 3,848. The epidemic curve shows that the outbreak began rapidly on August 5th when 97 cases were reported to the Guji zone. There were 5 peaks overall: August 8, 223 cases, August 12, 236 cases, August 15, 210 cases, August 17, 219 cases, and August 22, 220 cases. The number of cases steadily declined thereafter, and by the end of September, the outbreak was nearing its end. The number of cases in Guji was so disproportionately high that the curve for the total number of cases closely approximates the curve for all the Guji zone. This figure gives the age and sex distribution of the patients with cholera going to the CTCs for treatment. There seems to be fewer reported cases among infants and children. Furthermore, frontline healthcare workers indicated that there were more cases among men. The age categories given here represent the categories used for data collection at the CTCs. Available demographics for Oromia were not detailed enough to determine age and sex-specific attack rates. Attack rates were calculated for the regions within each of the zones. The attack rate ranged from a low of about 0.03 in Boro to a high of about 4.12% in the Grija and Adola districts. The overall attack rate for all three zones was almost 0.50. These rates do not include community case and therefore likely underestimate the true attack rate for the entire population. To assess the adequacy of the epidemic response and to evaluate the quality of medical care at the CTCs, CFRs were calculated for each of the districts. The CFRs ranged from 0% in Dugoda, Bora to 6.4% in Wadera. The overall CFR for all three zones was 1.11%. The numbers of deaths represent only deaths that occurred at a CTC or were reported to healthcare authorities. Community deaths were not included. To bring the cholera epidemic to a halt, short and long-term control methods were implemented. A combination of community and health facility surveillance aided the response. At the district level, Kabali chairman, local community members appointed by the governor to act as village administrators were targeted for an educational campaign which included recognition of AWD and early transport of all patients with AWD to a CTC. Kabali chairmen were provided with oral rehydration salt sackets and were instructed to provide oral rehydration salt to all patients with AWD during transport to a CTC. Their role also included a community awareness campaign that focused on personal hygiene, sanitation, water purification, and the need to rapidly identify and transport all patients to a CTC. Most people in rural Oromia drank unsafe open source water, putting themselves at risk for cholera and other waterborne illnesses. In the town of Gnele, Guji zone, the UN had established a safe water point where water was chlorinated, stored in bladders, and then gravity-fed to taps for distribution. Sanitation was also lacking in Oromia. Rural residents typically defecated in the field. In Guji, latrine coverage was estimated at 2% in the rural villages and 25% in the towns. The community response to the cholera outbreak included a campaign to build household latrines, and in Ishua, almost 2,400 household and 650 communal latrines were constructed during several weeks. Medical management of the outbreak was based on MSF guidelines and seemed to be appropriately implemented at most CTCs. Staffs were encouraged to be more assertive in initiating IV access and treating with sufficient amount of Ringer's lactate. Antibiotics were generally used appropriately, and staff were knowledgeable of the criteria for mild, moderate, and severe dehydration. Of medical supplies, oral rehydration salt and Ringer's lactate were in shortest supply. For example, in Ishua, the first recognized cholera patient died because only 2 liters of Ringer's lactate was available at the health post. In all three zones, doxycycline or tetracycline was the antibiotic used to treat severe adult cases. Ampicillin or erythromycin was used to treat severe pediatric cases. To conclude, not every case of cholera was being reported using the combination of community and health facility surveillance, and there were likely unreported deaths in the community. However, staff at district and zonal health bureaus were confident that most cases were being recorded because they believed that all recognized cases were examined at CTC. The government of Ethiopia's failure to acknowledge a cholera outbreak had several important implications. First, it meant that the World Health Organization could not assume responsibility for managing the epidemic because this requires that the state declare a cholera outbreak and request assistance. Second, without official declaration of a cholera outbreak, there was a delay in accessing donor funds. Declaration of a cholera outbreak might have resulted in a much more vigorous international response, and resources might have been mobilized much more rapidly. Finally, refusing to acknowledge a cholera epidemic weakens the chances for ongoing surveillance to recognize the potential for cholera endemicity in the region. Thank you.